panel members here who are Dr. Michael Pinsky and Dr. Ronald Kaplan. And Dr. Pinsky, I love it when we get the action shot. And
well, I'm just about to be taking a subject up to the roof to put them on a helicopter to fly them out. And so I'm overseeing that from other people. It'll take about 2 minutes, but I'm willing to listen in for those 2 minutes until that's done.
Man, this is definitely a positive aging discussion first. And you take all the time you need, and
I'll be just a couple of minutes, I promise. Okay.
Okay. Yeah. Just either log out or just mute yourself. And
I'm just going to mute myself. Okay.
Okay. Sounds great. Okay. Excellent. Man, Dr. Kaplan, that's a pretty action-packed co-partner that you've got there, Dr. Pinsky. I can't wait to learn more about what they're doing. Hopefully he'll share that with us. And then, but while we're waiting for Dr. Pinsky to come back, let's get to know you a little bit better. First off, you're the editor of the Care of the Older Person, which is a phenomenal book. And let me share this with folks. Where are we at here? Okay, here we go. Care of the Older Person. And so I'm going to share the website with everybody there so you can check it out. We've also got a special discount code if you're interested in purchasing the book. But this is a phenomenal book that has multiple authors, and I think you have the honor of being the editor, correct?
I certainly do have that honor, and thanks to eminent people like Dr. Pinsky, who, as you've just seen, is right on the cutting edge of research and to the benefit of all older people, and is in a very dynamic place. We have 65 eminent authors. I wrote a chapter myself, but there's 49 chapters. Dr. Pinsky, of course, wrote one on critical care. Dr. Pinsky holds multiple hats at the University of Pittsburgh. Besides being chief of critical care, he holds multiple professorships, and he has all kinds of very important research going on. And it was nice of him to come on today to share his expertise with us. I myself am Emeritus, which means they put me out to pasture. I'm a clinical associate professor emeritus of OBGYN at Weill Cornell Medical College. And previous to that, I was at McGill University. It was a group of eminent experts at McGill University of Montreal, Canada, that we put together to start this book, I don't know, 7 years ago, something like that. And the first edition was this very small thing that a doctor or any other caregiver could just put in their lap coat pocket as they made rounds, saw patients, use it for reference. Well, right now we got this big book, as I said, 65 major contributors, and it's just packed with information. The reviews have been gratifying. Some of them are posted on the website, and this book is being used for formal teaching, and obviously could be used informally by anybody who just wants knowledge.
Let me pull up on the website. One of the things I love about your website is you've actually got the table of contents, which is extremely robust. But as folks can see, and let me try to make this as big as possible, but as folks can see, it's broken into, I think, 6 parts. The first is part 1 is helping, part 2 is vulnerability, part 3 is caring, part 4 is cancer, part 5 is considerations, and part 6 is understanding and protecting. Part 7 is medical terms and a medical term glossary. And as you can see, folks, the chapters are extremely robust and on some topics that I have not seen in other resources. How first, to get into the inside baseball, how did you, number one, gather together this collection of what'd you say, 16 different authors, or
65,
and then sort of figure out how to put this framework together?
Well, considering I've been on the faculty of 2 major medical schools, it took a bit of doing, and it took years to do, but I'm 85 years old. I'm among the oldest old. I'm the youngest of the oldest old. It starts at 85 after you pass your 85th year. And in that amount of time, you get to know an awful lot of people in your profession, whatever you do. And you get people together and they know other people, right? And everybody knows who the big experts are, like Dr. Pinsky. So we went out and we got these people, and they all were very good about taking off time, which very few of them actually have time, to write this book. And that's how you get the expertise. You can't start something like that cold. I mean, well, I've been working on it 7 years, but really I've been working on it my whole life, because you have to build up the contacts, but not only the contacts have to believe that something's really going to happen, right? Somebody doesn't want to write a chapter for a book and then find out there's no book.
Right.
It hasn't been published or some other thing. They have to know that they're dealing with credible people. In other words, which I've never brought up on a webinar before, but one of the most important things you have in life is your word. You have a track record in your word, and people have to believe it. And they believe it if they know you can do something.
Man, I love it. Well, I'm sure we're gonna dive into the book, and when Dr. Pinsky comes back, we can learn about all the interesting research and projects that he's involved with. But what I like doing with folks like you is, and there's Dr. Pinsky. But
Can you hear me?
yeah.
Okay. Hi, Ron. How are you?
Excellent. How are you?
I'm up on the 14th floor of the University of Pittsburgh Medical Center, and there's a helicopter right outside. And I just sat down, and we're wheeling a patient out to go out to an advanced support system. So I was and unfortunately, weather is coming in, and they had to leave immediately. And it was right when we were going to start the webinar. What can I say?
Man, I love it. It's this is, like I said, I feel like I'm on Action Now News or something like that with the story like this. But Dr. Pinsky, can you, well, first off, I mean, we're really curious about the helicopter and the patient.
No. That's the Stat Medevac, transferring in, having to do with using resource efficiently for critically ill people. But the topic we're supposed to talk about today is the care of the older patient in the ICU.
So first off, tell us a little bit about your background, and I'd love to know a little bit more about you, and then sort of some of the research and the topics that you're involved with related to older adults.
Well, I was graduated from McGill Medical School, which is one of the best in the world. Back 50 years ago now, it'll be our 50th reunion this year. And then did an internship and residency at Stanford in medicine and then a pulmonary fellowship there. And then I moved to Johns Hopkins to do advanced physiology. And then in 1981, I moved to the University of Pittsburgh to be the first director of the medical ICU and as a pulmonary doc, and also to launch my own cardiopulmonary research lab. From the research lab, we were able to study complex interactions of heart-lung interactions, septic shock, how to resuscitate a patient, and to define health and disease from a cardiovascular perspective. However, at the same time, in parallel, I was a full-time ICU attending as a professor of medicine. And the thing that you learn very quickly is that the elderly patient doesn't behave like a young patient for the same problems, and they don't present the same way. They simply don't. I'm sorry, it might get a bit noisy here because there's a helicopter landing. I apologize.
We can hear you pretty well.
Oh, good. So what we were saying is there's several things that are important when you're dealing with the care of the elderly patient. First of all, the classic things we teach our medical students about the symptoms and signs of disease are often blunted or lost. They do not have to look as sick as they would. As a matter of fact, one of the more common things that happens for an elderly person that are septic or becoming hypotensive or the myocardial infarction is they get confused. Developing hyperglycemia, high glucose level, one of the first things you do in an elderly patient is do an ECG and do a urinalysis to see if they have a urinary tract infection, because those are the more common. So the first thing we teach the residents is that when they're dealing with the critically ill elderly patients, that they have to have a higher index of suspicion as to what is happening, and don't assume that classic patterns are going to be the case. The second thing is, and one of the things I've said for many years, is that elderly patients, when treated, do nothing fast except die. So don't aggressively resuscitate. Think of it like you're flying a 747 through a storm and trying to land them. No sharp turns, steady at the wheel. Don't go up on the fluids. Don't change the level of PEEP if they need it. Don't go up and do things slowly. And even if what you give them is the right thing to do, you may not see an immediate response that you would expect to see in a younger person for maybe 15, 20 minutes or much longer still. So you have to have much more of a nuanced approach to their care. And the final thing is that the older you get, what you get, and this is in my chapter, as you get older, whether you like it or not, you're reserved to be able to handle anything. And I'm an old man too. I'm in my 70s. Your reserve when you get older is much less. And so the same insults that you would have as a kid, like taking a bicycle and falling off the bicycle, and you don't even think about it, you don't tell your mother, you just get back on the bike and you go. Well, if you did it at our age, you'd be really hurt. And so two things, the cardiovascular and endocrinologic and metabolic reserve of the elderly patient is profoundly limited. They do not have homeostasis, they have homeostenosis. They are limited in what they can do. And so when people say to me, my father or mother had been so stable for so long, why are they doing so terrible now? My response to them is, thank God that they were able to not have to have these problems. But all that happened when the stress hit them is you're unmasking the fact that elderly people are frail. That doesn't mean they can't recover. And the final thing that I say is that when an elderly person comes in and you don't know anything about them, you always opt for life. It may well be that this was not oh, hold on a second, I have to see this. I apologize. Is it about to lift off? Okay. Okay. All right. We're not going to go into details here. We're making history as I speak. But okay, there's a helicopter. I don't know if you can see it. See it? I'm sorry, I had to turn back. Anyway, we're doing a totally autonomous closed loop resuscitation with no human being taking care of the subject. And it's in a helicopter right now.
Wow.
Yes, this is the second of 4 we're going to do, and after the 4th, we're going to submit the paper, and if it's accepted, we'll have a press release. But that's going on now. But the last thing I say is that when you have a patient that comes in, they're sepsis from urinary tract infection, or maybe a perforated bowel or pneumonia or something, you always opt initially for life. If they need aggressive resuscitation, you do. Once the dust files and the family comes in, if they were to say, no, my loved one did not want aggressive resuscitation, that's okay. There goes the helicopter now. That's okay, because you can always then withdraw the care while maintaining comfort. But you never want to take away the opportunity acutely, unless you know the patient. You know the patient, they don't want anything done, that's another story. But oftentimes in our modern medical system, we don't have that luxury. So in that situation, we always opt for being aggressive to support, and then turn around and find the family and say, what does your loved one want? And then we then can limit care there. So that's basically the things that I've learned over the years.
Man, this is just so insightful, and it's great to hear from both of you, experts in the medical field for many years who are taking the time to sort of quantify the your thoughts on serving older adults. A question that I don't know if you get, but it sounds like both of you are working in the teaching realm in medical schools. Is there anything encouraging about getting more doctors, especially more young doctors, to think about serving older adults as their primary practice? I know that we're woefully inadequate in actual geriatricians that are practicing.
Ron, did you want to answer that?
Well, you're perfectly right. There's a shortage of geriatricians, but if you look at the big picture, there's always going to be a shortage of geriatricians for the very simple reason that older people, as Dr. Pinsky has said, need a multi-professional approach. It can't really be taken care of by one person. The geriatrician can oversee and be the nominal doctor to the patient and give advice and actually treat. But when the rubber hits the road, you need Dr. Pinsky and people like Dr. Pinsky to come in and save the patient. The other thing is, when we started this book, we figured that now, 7 or 8 years later, there'd be 50 million people 65 and over in the United States of America. In fact, I think it's over 60 million now. And we're having the same problem as other industrialized nations, such as Japan, China, etc., where we have aging populations. The birth rates are down for various reasons. And at the same time, the population of older persons has gone up enormously, except for this glitch the last couple of years where we had COVID and people were dying from COVID, and that sort of skewed the statistics. But now I think we're getting back on track, although COVID's still sitting around in the background somewhere and keeps changing its nature. But we're back to getting an increasing number of older people in the United States and around the world. And the fact is, you'll never have enough geriatricians to take care of, say, in the United States, hands-on 60 million people, right? So that's why we put out a book for caregivers everywhere, encompassing a huge number of topics, so they could get familiar with how to deal with older people, one-to-one basis. And my if I have to say one thing about that, I always say the same thing. Don't be condescending. Some of us are a little smarter than you think. And if you start talking to us like children, we get very upset. So it's important that caregivers on every level get to know a little more about how to deal with elderly people, because aside from, say, pediatricians or people who take care on all levels of young children and babies, I don't think there's a caregiver who isn't in one way or another coming into contact with older people who need care. And so you have to take this wider approach in order to get care out to everybody. And then, of course, there are people like Dr. Pinsky who are worried about people in remote areas and underserved communities, and how do we get good care to them? And Dr. Pinsky could elaborate.
Wow, I'm glad you brought that up, Dr. Kaplan, and I'd be interested in your thoughts, Dr. Pinsky, because I actually, a member of my family, or extended member of my family, lives in an extremely remote area, in northern New York, right on the Canadian border, and she had some healthcare issues, and it was just, driving hours to get treatment every day. It was, are there some hopeful developments for folks that may be in more remote areas?
Well, we refer to this as a medical desert. And there are significant medical deserts in every state. I live in Pittsburgh, and in Pennsylvania, the central area of Pennsylvania, there are significantly large degrees of underserved people who don't have direct access to advanced care. So what we've been able to do, at least within a healthcare system, is create a telemedicine network that allows for the expertise that's remote from those to be seen by a nursing aid station in a smaller hospital, and if necessary to triage up either by helicopter or what we're at right now, helicopters or an ambulance to a different area if necessary, but to not do it if it can be treated where it is. But I wanted to get back to the teaching part. As Dr. Kaplan said, every doctor that takes care of patients, with the exception of pediatricians, is going to be seeing significant number of elderly patients and medical students. Our medical school is associated with the Oakland VA hospital. Average age of a VA patient is like 72 or something like that at our hospital. So as they're in their training and clinical rotations through the VA hospital, they're seeing elderly patients. With the exception of cardiac surgery and liver transplant, which tend to be younger patients, the medical ICU patients we have and the other patients, there tends to be an older age group that clearly is a spectrum of ages, but in their education, the students are being shown on a daily basis critically ill or complex patients that are elderly. And this is where we teach them that. And I also agree with Dr. Kaplan that the gerontologist is a wonderful person to have, and I think they're great, but their strength is really outpatient. Trying to identify the right medicines for Alzheimer's or for confusion of other forms and various other, the brilliance that's necessary to titrate that carefully is a clear skill that they do extremely well. Well, when we're talking about acute illness that requires hospitalization, I think most acute care centers in the United States are used to being having experience with elderly patients. What we don't have is a medical desert problem. And in the medical deserts, wherever you are, whether it's in Pennsylvania, New York, I assure you New York has medical deserts. And also, we see this in Maine, areas in central Massachusetts. I don't think there are any in Connecticut that I'm aware of, but there are, and those are very populated states. You would not think of them as not being able to have, but they exist. And so what we need, and we've been doing at least at the University of Pittsburgh Medical Center for the last 42 years I've been here, is creating a network with computers and the ability to video conferencing and direct concepts. So when they do a CT scan, for example, we can see it immediately. which is amazing. So imagine a neurosurgeon or a neuroradiologist seeing a CT scan as soon as it's done, 300 miles away, to say, yes, get them on a helicopter now, start TPA, this is this, or no, they're fine. So that sort of just-in-time expertise is, I think, going to be one of the things that in the future will significantly amplify the workforce where it's not present.
I love it. And I've never heard that term medical desert, but I'm very familiar, and I've seen and heard stories of folks that have been really compromised because of their geographic location. So this is encouraging.
Acute coronary syndrome, and they can't be seen for an hour and a half. That's a very bad place to be.
Great. Now I'll throw this out to both of you. Because whenever I get experts like the two of you, it's like, what's on your minds now? Like, what are some of the things that you're kind of seeing on your radar, or sort of words of wisdom that you can offer to folks that may be concerned about themselves, their own health, or their mom and dad or loved ones' health? Any sort of random things, and I'm also to our community members that are listening to this, if you've got any questions related to some of the things that Dr. Kaplan and Pinsky are saying, feel free to jump in and throw your insights in there as well. But anything on your mind that you really want to kind of share?
Well, one big thing, of course, is the discrepancies in medical care, not only around the world, but as Dr. Pinsky said, in this country. Geographically, we're a huge country, one of the largest on earth. And even with all the modern technology, it's sometimes hard to get the right person to the right place, or as Dr. Pinsky said, to get the patient to the right person on time, which is obviously what he's working on right now. It was a very big problem in obstetrics when I was practicing. And that's not pertinent to this discussion, because obviously the vast majority of those patients were much younger. So I won't go there, although it is a very massive issue. But as far as discrepancies go, people have used that politically to tout this kind of medical system or that kind of medical system. And what you have to realize is this country, the United States, we spend more on medical care per year than the gross national product of most countries. In other words, when you see another country has this or that medical plan, very often they're a much smaller country geographically, they're much more homogeneous. They have a lot, sometimes less social problems, sometimes more. But what we spend on medical care is massive, and we do have, on the level of people like Dr. Pinsky at University of Pittsburgh and other top centers, we have the finest medical care in the world. I don't think anybody would dispute that, and if they do, they're not telling the truth. But the trick is, and it's really complex, is to get that care out to every single person who needs it. And I have a very basic approach, because I think it all begins with the educational system. And if your population has to be educated to the level where they understand what's needed for their own health and safety, and so that they live healthful lives. It all begins there, and obviously in the home. So it's the home and the educational system. So you're talking about your social system. And then one leg of it, that's one leg of it, the entire social political thing, which is enormous. And then, of course, there's the whole medical thing, which is new drug innovation, innovators like Dr. Pinsky who are on the forefront of research, and then translational medicine, which is also what Dr. Pinsky does, which is getting it out to the people. And that's a huge topic. And then, of course, the third leg of the whole thing is what the person does for themselves, having that knowledge, having that medical help, having a stable society. It's no use having the best medical care in the world if you're afraid to go outside your front door because your society is unstable. So these are massive, huge issues. And if you look at the amount of money that the United States spends on medical care per year, it's probably the biggest part of the US budget.
And more than that, Ron, we spend more per capita in the United States than any other nation in the world. And with the healthcare disparities, it means that some people are getting a lot of care. I was going to say that the education has to be in many ways. Patients and their families need to be advocates for themselves and for the use of care, not demanding that you do a specific treatment, but demanding that you get the assessment that's necessary because you're concerned. And to a certain extent, this requires a level of education, which is not given normally in schools or anything, because we don't normally say, what do I worry about with the elderly person? So the families need to be present when the patient comes in to see the doctors too, to know what they should be looking for. This healthcare disparity is more pronounced in the United States than it is in Canada, for example, which has universal healthcare, but they still have it there too, because there's no really good answers. But I think to the degree that we could have a form of socialized medicine where the cost of drugs and the cost of service doesn't vary by your income or your insurance, I think would allow people to come in and see what they're doing more. But at all times, healthcare is a social contract between the society, medicine, and the patient people. And the people are one of the parts of it. And they have to also take care of themselves, try not to do destructive things like eat too much or smoke, and keep their blood pressure down if they're hypertensive, while and exercise and all those good things you're supposed to. But they also should expect that if they need help, they should be able to get it. And for that, they should be their own advocates as well. And so I don't mean to have the answer. There is no answer that we can give you this short, but I do believe it's not a simple one. But I do think also the degree to which we have a more universal health system and drug costs, Medicare is phenomenal, but if your children get sick without insurance, you lose the house. Yeah, that should not be.
You're right. Okay, Deborah has an interesting question, and I'd be interested in your thoughts on this. And she says, in our culture of winning, we seem to have lost track of the body's ability to die gently. If doctors in training are learning about technology and drugs as a way to treat patients, are we supporting patients through their final journey? The thought of CPR, if my loved one stops breathing, is distressing if his ribs are going to be broken. And so I guess she's, sort of throwing out sort of her personal thoughts, but this whole end of life debate, and especially when it comes to, being in a medical facility and trying to do something, curious about your thoughts on end of life as two esteemed medical professionals.
Well,
we see a lot of it, right? I was saying, Ron, we see a lot of it. Many patients at the end of life who haven't thought about it end up in the ICU first. I think hospice, we do hospice care in the ICU for sure. I think there needs to be more proactive discussion in a realistic way. And that, I think there was Bush brought up this thing of having these panels that would look at people and see what they wanted to have done. But unfortunately, in the next election, the Republicans called it death panels. And so they canceled them, even though they were the ones that came up with it. It was so frustrating. Because if you could allow families and their just to talk to physicians, say, what's realistically down the road? And what do we want? Most people have a very realistic idea of how they expect to go. We are very good at being gentle, allowing people to pass with minimal discomfort and with dignity, if that is a decision. But oftentimes we aren't told that's what is wanted.
Yeah, I think this is one of these topics that always comes up on our discussions is that if they're coming in and pulling you out of your house and taking you to the emergency room and they don't have any direction, I think, like you said, you've got to make an assumption that life is the first thing that is most important until somebody gives you contrary information.
Right. Ron, you were going to say something. I interrupted you. I'm sorry.
No, that's okay. I agree with everything you said, obviously. I think a little bit of preparation helps here. It's almost unfair that people like Dr. Pinsky and his team are confronted with patients in critical states, and they don't have the knowledge to know exactly what those patients' wishes are at the moment. This can all be done in advance. We have a good chapter in the book by an elder care attorney, tell you what kind of papers you need. It's really easy. You make your papers in advance that the hospital needs, that your loved ones need, include things like a will, an advance directive, and then there's no hesitation by the medical teams. They know going in, especially if you have a relationship with a doctor, they know going in what your desires are. It's all in your chart, it's all in your records, and they can proceed accordingly. And if you look at the last chapter in our book, we talk about how you have to respect everybody's beliefs. And that's very important, obviously, too. We're here as doctors to serve everybody. We serve our people. And now that I've become more patient than doctor because of my advanced age, you get to see both sides of it, and you start to realize, yeah, a little compassion goes a long way.
Yeah. A question about medications is that so many older adults are on multiple meds, possibly seeing multiple doctors, and I've heard this from emergency room doctors that, you know, when somebody comes in, they're trying to make split-second decisions, but they don't know, you know, all the drugs that they might have in their system, and it can be really challenging. Any thoughts on, or are there some solutions that you all your teams are talking about in terms of managing the meds that people are on, and how they could counterbalance and sort of show signs of dementia when somebody doesn't even have dementia?
Yeah. Well, there was a New York cartoon, New Yorker cartoon or a joke, and it was this picture of a sign in front of a hospital that says Dr. So-and-so medicine, Dr. So-and-so surgery, Dr. So-and-so side effects, you know. And the point is that the drugs we give today tend to have very specific profiles of sympathetic and parasympathetic, dopaminergic stimulations, et cetera, oftentimes which are secondary, not needed, and many times because they're specifically needed to improve attention span, et cetera. But then if you then couple them with diuretics, which will change your electrolytes and things like that, they can cause instability in ways that you would not appreciate. And one of the things that if you have a healthcare system where the person is in that healthcare system, even if they're an outpatient, when they come in, you have access to their electronic medical record with the computer-assisted physician order entry, that you already know every drug they're on, and you already have a system that says, you know, these are side effects of these two drugs interacting, and you'll see stars for that. I've been amazed constantly at what I thought was a real disease, which was really too high a dose of something. And you turned out, oh, what do I, that was good. Got to write that one down. But it was already in the computer at the time, which you cannot teach or know all of these interactions. It's just too much. So what you really, excuse me, I'm going to sit down. What you really need to do is have such a system. If you are lucky enough to be in a system where the doctors, all the doctors, whoever they are entering the same things in the same medical record structure, then the potential for adverse drug interactions to occur inadvertently becomes much less.
Yeah, are you all hopeful that we're going to see some systems like that? And are there some example? I know the VA is very good at some of these electronic systems, but have you heard rumblings that we may be getting close to things like that?
I've heard nothing.
Okay. I was hoping for some hopeful news.
I was a VA employee. I ran the VA for the ICU for 18 years. It was wonderful. A patient could come to me from California, Long Beach VA, and I knew immediately their record. And this was years ago now. So the technology available for the important stuff that we want is already here. It just requires there be some degree of coordination.
Yeah, and that requires, I guess, a little political wrangling and people sort of giving an inch to have a consolidated system that everyone's using, which is no minor feat. But well, man, this has been an amazing discussion. And but I just, like I said, I mean, the inside baseball here with the helicopter on the top of the building and the experimental procedure that's going on is amazing. Now, of course, whenever I say something like that, then a question pops in. So Megan or Margie says, one of my biggest challenges is getting information about available support for patients and families out there, is that the medical providers and their support staff are so busy. We have the ability to support them and make their jobs more manageable, especially since COVID. It's very hard to get time with social workers, nurses, and other medical professionals in medical practices. Do you all have any tips on, so like providers out there that can provide support to your patients, any tips on how they can better communicate with medical teams and practices?
Well,
Ron.
I think that, first of all, one of the major problems we have is this dire shortage of nurses. And it's only becoming worse in these last few years for obvious reasons. The stress factors are incredible. The person who asked the question is perfectly right. It's very, very hard to get to talk to a doctor, a nurse, because we're all so busy, doing so many things at once that it's really hard to get time to just answer these kinds of questions. There are fortunately databases and things like that, but that's not very personal. So I defer to Dr. Pinsky, maybe has better ideas.
Thanks. I don't. The problem, the real fear I have, and I see this a lot, is that people go on the internet and they look at databases and they get, the expression is sophomoric. They get some knowledge, but it's totally misunderstood and misconstrued. We have this confirmation bias and ignoring things we don't like, such that we assure that what we're doing is the right thing or what we're doing is the wrong thing, and we agree something else is happening and you want to see some treatment, whatever it is. And so, though I'm a big fan of us using the data that we have out there, there should be within a system the ability to have a structure. Now, I don't mean to support the UPMC program because I think that's biased, but one of the things that we put in years ago, and I was part of the group that pushed it, was a medical concierge system, which was that if you didn't if you were in UPMC Health Plan, which is the largest health plan in all of this area, southwestern Pennsylvania, okay, so it's the majority of the paid people here, you can call this number 24/7, and someone will help you get schedule through all the scheduling you need to do or something. If you have a problem, if you're befuddled, okay, you just call it. And it was almost like an ombudsman, but we call it a concierge plan, because the person would be able to directly interface with your own physicians, pull up your medical records, see the drugs you're on, et cetera, with your permission, of course. And that has been a big success in the southwestern Pennsylvania, this area. And so hopefully it'll be useful, but it's totally and completely limited to people that are part of a specific healthcare plan that has this information. So it's not generalizable at all. So I don't have a silver bullet for the group, but I do think that if you have a healthcare system that you're in, you should be able to get outpatient and inpatient control and stuff as part of it. And then there's the problem with people that are elderly. They can be snowbirds. So they're going to spend 6 months in someplace south and 6 months in someplace north. They're going to have two separate medical records. You know, I see this a lot. I don't know the answer to that one either.
Yeah, no, a lot of challenges and things that we definitely need to be thinking about. Rosalind says, number one, the main improvement is to reduce hospital errors. And number two, listen to seniors, recognizing seniors that know well their health, medicine, and allergies. I guess a lot of training in med school is probably about, well, should be about communication. And, you know, it's beautiful that we are living in a much more inclusive world, but there seems to be a lot of ageism that's still out there. And I think, you know, teaching the young medical students that, look, we're all kind of seniors in training, as Dr. Kaplan has sort of has cited a couple of times, is that, you know, when you reflect back, Dr. Kaplan, as a medical student, and, you know, how you viewed your patients that were 85 years old plus, you know?
Well, hopefully with compassion, but we did not have the kind of knowledge then of how to keep them in optimal health. We had some, but nothing like Dr. Pinsky and others have written in The Care of the Older Person about how to keep older people in optimal health so they could, say, get to an operating room and survive the surgery. A transplant surgeon who's written in the book made the excellent point that there used to be age limitations on people who could receive transplant organs. Now there's not. You could be any age just about and be made fit enough very often to get through a transplant operation and subsequent care and live longer. And we all have a life expectancy, of course. Doesn't matter how old you are, you have a life expectancy. So there's always something to look forward to.
I love it.
I'm gonna say, it'll be slightly off color because it uses the word sex, but it only uses that. When I talk to the medical students every time until about 3 years ago, when I stopped giving first year medical class, I would say to them on the very first day, life is a sexually transmitted terminal disease. That your patient is sexually transmitted. I assure you, your patient and you are both going to die. So if you think you're saving lives, you're merely postponing death. What you really should be doing is maximizing the quality of life within the context of health. And it is not your definition of quality of life that matters, it's the patient's. So at all times, you're a consultant to the patient on what it is that they see is what they want.
Man, Dr. Pinsky, you're getting a lot of thumbs up on that. And I may have to transcribe that quote because that was very well said. And I think it's something for all of us to think about in our own lives, but if we are medical providers, to be very, very aware of that. I see we're getting close to the top of the hour. Number one, Dr. Pinsky, especially to both of you, thanks so much. But Dr. Pinsky making the time and adding this element of this, it is amazing, and I'm absolutely blown away at how good your sound has been throughout the whole time. Because given that you're there in this crowded, action-packed room is absolutely amazing.
Okay, well, thank you. I'm up in the helicopter port, so it's a little bit quieter because I asked the people next door to close the door. Since I'm one of the most senior people in the hospital, they usually do what I ask. But
listen, that's one of the benefits of being an older adult, right? In fact, when I was talking to Dr. Kaplan, is like, how did you pull this book together? It's like, look, I've been practicing medicine for, decades. And if you have a good plan, you got a lot of good connections. So the two of you are definitely elders that we all need to respect and aspire to reach the positions that you have in your profession. And we're all lucky to have folks like you in the medical profession. Any closing words? Dr. Kaplan, don't worry, I'm going to distribute all the info on the book and getting the discount and all of that with the recording as well.
Well, the only last words I have, and I hope they're not my last words, is be healthy and like Dr. Pinsky said, lead a meaningful life. And that's about the extent of it.
I love it.
Okay.
All right.
Thank you for inviting me.
Oh, you bet. This has been the pleasure has been mine to be able to speak to both of you. So, all right, folks. Well, we'll have the recording. Thanks so much. And everybody have a great remainder of the week.